Good evening, students. Today I am here once again and to give you some tips about the exams. So I again repeat the same one thing that you must pay attention on the question paper. क्वेश्चन पेपर जब तक आप नहीं देखेंगे ठीक से आप क्वेश्चन नहीं पढ़ेंगे हाउ यू विल डिफाइन योर आंसर what you have to write and what you don't have to write. So pay attention on each question what is being asked and plan your answer according to that, and then write the answer in heading, subheading, label diagrams, flow charts. So whichever is comfortable to you. Be comfortable in leaving a space between the heading, subheading and between the two answers, so that examiner have should not waste time in making out where one answer starts and where one ends. So today I will discuss about sinus and fistula. These are the common things which are discussed in general surgery for dental students as well as general surgery for the surgery students. So these sinus and fistula are day to day problem in, you can say, the surgery field, and the common factor that lead on to the non healing of sinus or fistula. So these are the common factors that also cause the non healing of the wound. One thing. Second thing is the presence of granulation tissue and the continuity between the two organs or two hollow viscous or the surface with the hollow viscous in case of fistula, and the presence of pyogenic material foreign body in case of your sinus. So sinus is a blind track and the fistula is a abnormal communication. So you have to add this one, abnormal communication between the two hollow viscous or two epithelial surfaces or one epithelial surface to the exterior of the body. That is the, suppose it is a communication between the hollow viscous like your intestinal tract with the skin surface, as in case of fecal fistula. So these kind of fecal fistula usually arises in case of leak of anastomosis, where we have done already surgical procedure, and in that case there is always a weak point for the fecal matter to come out. Suppose in case of perforation without any surgical procedure over the abdominal wall, it will keep on accumulating inside the peritoneal cavity and lead on to sepsis and ultimately the death of the patient. So you must be very careful in defining your definition and writing your answer. So sinus and fistula, you have to write everything about sinus and fistula when it is asked. When only definition is asked, you have to give only the definition. When the causes are asked, you have to give causes. Don't write everything that you know in a answer that is expected from you for in a few lines. सो इतना भी ज़रूरी नहीं है कि आपने 2 नंबर के मार्क्स के लिए आपने पूरा एक पेज भर दिया. किसी के पास इतना टाइम नहीं है कि वो पूरा ये चेक करे कि आपने क्या लिखा और क्या नहीं लिखा, whether you have written some relevant things or irrelevant things. So when you write to the precise answer, the examiner will be happy and he will give you good marks. So when you write too many things, that means you don't know the answer. You only know that this is the chapter or this is the topic, and you have written everything that you know about that. So that also gives that you are not applying your common sense, you are not applying your knowledge in writing or defining the answer. So let's start with sinus and fistula. Once again, I repeat, pay attention to your question. And if you like this my video, please share with your friends and don't forget to subscribe the channel. Thank you, and let's start with sinus and fistula. Welcome. Enjoyed the music? So our classes used to be like this. I'm Dr. R. K. Dua. I am a founder of Fun, Learn and Earn system for the dentist. So today's class or today's topic is sinus and fistula. So what is sinus and what is fistula? If we see anatomically, both are almost similar with one difference, that in case of fistula, there is communication between the two epithelial surfaces. But in case of sinus, there is a track that is going from the surface like this and it is ending in a blind cavity or the blind track. But in case of fistula, these are two epithelial surface cavities, suppose, and there is a track in between. So that track is communicating this epithelial surface cavity with this. So there is a track in between the two. But in case of sinus, only this cavity is there, or it could be a blind track just like this, and it may be ending in a small cavity, or it is directly ending with the blind end. So there is only one communication in the case of sinus, that is to the surface of the body. But in case of fistula, there is communication between the two epithelial surfaces. So that may be gallbladder with the colon, gallbladder with duodenum, or you can say colorectal fistula, colon with rectum, or colovesical fistula, colon with urinary bladder fistula. So there are two epithelial surfaces, and one there is a tract that is communicating between the two epithelial surfaces. So this is known as fistula. So sinus is a blind tract lined by granulation tissue. So this term, that is the granulation tissue, is very important, because the track which is communicating the two ends in case of fistula only to the surface in case of sinus, it is lined by the granulation tissue, and this granulation tissue once formed, this causes or this inhibits the closure of the fistula spontaneously. So it is very essential to remove the granulation tissue and lay open the track of the sinus and close the two openings of the mucosal surfaces in case of fistula, and close those openings and remove the tract that is causing the communication between the two epithelial surfaces. So until unless this granulation tissue is removed, the sinus or the fistula is not going to close with any kind of treatment. So what are the various causes of formation of these sinus and fistula? So fistula can be formed in case of Crohn's disease, where there is involvement of the large intestine. It can perforate and can form a communication with the bladder with the other organ, whichever the organ is adjacent to the site of inflammation in case of Crohn's disease. Abscess with inadequate drainage, it will lead on to perianal fistula. So in this case, perianal fistula, when there is formation of the abscess just at the perianal area, suppose this is the anal opening, here this abscess forms. If patient presents in the first attempt, that is as soon as the pus formation or a small swelling is there in the perianal area, and you detect that it is a perianal abscess and you do the drainage of the abscess, so 99% chances are that the abscess will heal and there will be no fistulous communication. But what happens? Patient keep on lingering, that he will go to hospital or see the surgeon after 1 day, 2 day, or somebody has prescribed antibiotics and he takes on taking antibiotics. So what happens? This tract, suppose this is the anal opening, abscess was here. So ultimately this abscess spread more proximally. It may form tract here, it may form tract here. So as the abscess tracks out into various planes in the perianal area, ischiorectal area and above. So chances of complete drainage of the abscess and the complete scraping of the wall of the tracts of the abscess are low. So that leads on to recurrence of the abscess and ultimately it will convert into perianal fistula. So that perianal fistula in, has got multiple tracts, one going here, another going here, some going upward into the pelvis also. So they cross the sphincters, planes of the sphincter, they cross like this, it is going like this, and this is the sphincter. So it becomes many times very difficult to remove whole of the tract of the fistula without damaging the sphincter. So it should be taken care of in the initial stages. As the time goes on, that perianal abscess and ultimately the fistula keep on tracking upward and sidewards. So when the multiple tracts are present, so whatever attempt we do, the chances are that the recurrence may occur because of the leftover of granulation tissue or minor segment of the tract. So penetrating wound, if this penetrating wound goes into the abdominal cavity through the perianal area into the rectum and pierce the rectum, or in the abdominal cavity it pierces the bowel or the stomach. So what happens when the patient presents late? The content of the intestine or the stomach goes into the peritoneal cavity, and from that peritoneal cavity it comes out through the abdominal wound. So in delayed presentation, what happens? There is a formation of the granulation tissue between the stomach, intestine and the outer surface or outer wall of the abdomen. So this form a communication between the outer surface and the cavity of the stomach or your cavity of the intestine. So this is known as intestinal fistula or other kind of fistula, depending upon what kind of organ is involved. So iatrogenic fistulous tract, sometimes we do the colostomy, we do the ileostomy. These are iatrogenic. So these are deliberately prepared fistulous tract to enhance the healing of the proximal segment. Sometimes what happens, there may be accidental trauma to the intestine, perforation, and it was missed at the time of surgery, and ultimately it may present as a fistulous tract communicating with the abdominal wound. Then are the neoplastic fistulas. So all these neoplastic diseases has a tendency to invade the adjacent structures. If some tumor is there that pierce or penetrate the hollow viscous and it forms the communication between the two adjacent hollow viscous, and there is a formation of the fistulous tract. So in this case, fistulous tract will not heal until unless the malignant condition of the patient is treated. So it becomes very important to give the chemotherapy, radiation therapy, or whatever kind of treatment is required, along with the excision of the whole of the tract and the repair of the communication between the two epithelial surfaces. So what are the various causes of non-closure? And most of these causes of non-closure of the sinus or fistula are almost same as the factors which cause the non-healing of a wound. So if necrotic material is present in the sinus tract or necrotic material is present in the fistulous tract. So it is not going to heal in any time space. Second is presence of the foreign body. So most of the time the foreign body, in case of post-operative patients, some suture remains there and patient is allergic, and that to that suture, or that suture is not absorbed. So that may be silk or other kind of suture. So once that suture becomes infected, it forms the formation of the pus, and ultimately the pus has to come out of the surface. So if it is in the abdominal wall or the superficial surface, not communicating with any epithelial surface inside the abdomen, so it will form the sinus formation, and the sinus will heal only when that suture material or that foreign body is removed. Then the distal obstruction. Suppose there is a communication of the small intestine with that of abdominal wall, and such kind of fistula occurs when there is, you can say, we did the resection and anastomosis of the small intestine, and the conditions were not in favor of healing of a wound. So patient may be having some hypoproteinemia, already have existing septicemia, diabetes mellitus, and many other factors. So what happens in those cases, that fistulous tract is formed when there is leakage of anastomotic site, and the fecal matter used to come out through the abdominal wound after causing the dehiscence of the abdominal wall. So in that case, many times there is fistulas of the small intestine. If these are low output, these heal spontaneously, provided we have to replace the fluid that is being lost, we have to replace the proteins, we have to replace the nutrients that are being lost in the fistulous secretion. One thing. Second thing is that ultimately, what is the normal tract of the fecal matter? Normal tract of the fecal matter is going along the track of the intestine. So if suppose distal to the fistulous tract there is an obstruction of the small intestine or the large intestine, or there may be some structure that is causing the obstruction, so in that cases there is more stress on the suture line at the site of the fistulous tract. So ultimately what will happen, the fluid, or you can say fluid fecal matter, will make the tract through the fistulous opening. So in that case, if we make it happen that we ensure that distal gut intestine, or it may be colon, is totally free of any obstructive cause. That means colon or small intestine is not obstructed. So in that case there is free flow of the fecal matter into the normal tract, and slight leak from the fistulous opening will be there. Slowly and slowly there will be constriction of the opening, and ultimately the fistula will close within 10 to 15 days. So if this kind of things occur, most of the time these fistulas, if these are of low output, they close spontaneously. So foreign body and inadequate drainage. When some pus is there, as we have discussed in case of perianal abscess, when the patient comes in the late stage, pus has already tracked into various planes of the sphincter and above. So sometimes it becomes difficult to drain every track of the abscess and remove the granulation tissue that is lining the tract. So that is one cause of the non-healing of the fistula. Sepsis. If sepsis is there, so sepsis at the local site, sepsis as a generalized condition. So in both cases, in local localized case, there will be formation of the granulation tissue, formation of localized pus that will prevent the healing process. So it will inhibit the formation of the granulation tissue and epithelialization of the wound. So that will cause the delayed or non-healing of the fistula. So in case of systemic sepsis, what happens? Already the patient is immunocompromised. Septicemia will cause all the immune system down. So in that case, what will happen? The fistula or the sinus tract will be very slow to heal, or it will not heal until the total focus of the sepsis is removed from the body. Then the tract ramification. As I have discussed, the tract is going this time, this side, going into the various planes of the sphincter, upward, downward. So when we open the fistula or we open the sinus, it becomes very difficult to locate every fine tract. So these ramifications many times are left behind after the complete excision as we think. But actual thing is that some minor tract or minus granulation tissue with the tract is left behind. So that is the cause of the recurrence, and in these cases recurrence may occur after a few months or maybe after a year. So what are the various investigations that we have to do to treat the fistula or sinus? So there are two main investigations. One is the sinogram, another is the fistulogram. The sinogram means that we have to inject the dye into the sinus, radio-opaque dye into the sinus, and we take the picture or x-ray of the sinus tract. So that will give the exact location, exact depth, and whether the sinus tract is opening into some cavity. So that will give, or it will also give the information that this sinus tract is not going adjacent to any vital structure. That is one thing. Second is in case of fistula, that is a fistulogram. So what exactly is the fistulogram? We inject the dye through the fistulous tract that is in the abdominal wall, and this kind of lupogram we also do when we have to close the ileostomy. That means we have to check whether the distal intestine is okay. That means totally patent. There is no narrowing, no obstruction. Ultimately, what will happen when we close the ileostomy? There is distal obstruction is there, and the food will not go. It will make a back pressure and put a strain on the suture line, and ultimately the intestine will open up and we reach to a point where we have started. So before closing any ileostomy or closure of the intestinal fistula, we have to ensure that there is no distal obstruction. So flow of the dye should be till the rectum. There should not be any narrowing, or there should not be any tumor or any other extrinsic cause that is causing the narrowing or the partial or complete obstruction of the intestinal tract. So what exactly is the treatment of the sinus and the fistula? Just hold on. Let me close all the notes. So as we have discussed, in case of sinus, there is a blind tract, and we have to do, and this blind tract may be holding like this. This is a blind tract, and there is no communication of this small cavity with any other structure. So until unless we open this tract and open this cavity open and scrape out whole of the granulation tissue, so this cavity will not heal. So what we do, if there is a small tract which we have opacified with the radio opaque dye in the sinogram, So before doing any surgical procedure over the sinus, what we do, we inject small amount of diluted methylene blue dye. That dye will opacify the whole of the tract and the cavity that is communicating with the sinus tract. So we can, if it is a superficial and small, we can excise whole of the sinus tract. In case if we happen to open by accident, so we have to scrape whole of the tract till the opacive, you can say that colored granulation tissue along with the wall of the tract is removed, and whole of the ending cavity of the sinus is removed. So removal of the septic material, that we have to drain, complete removal of the tract. And when it is not possible to completely excise, what we do, we lay open the tract. Suppose this is a tract, we lay open the tract like this and scrape whole of the granulation tissue till healthy tissue is there and it is actively bleeding. So, and we pack the cavity with antiseptic solution like betadine after cleaning with hydrogen peroxide and the betadine solution. So we pack the cavity and let the wound heal by secondary intention. In this case, wound will heal from below towards, and then it will close by the epithelialization of the tissue. So what happens in case of fistula? So this fistula is connecting with this cavity, and this cavity we have to disconnect the fistula tract from this and from this. So we have to close this one also, and the communicating tract between the two. Either we have to remove it if it is possible. If it is not possible to remove the tract as a whole, we have to lay open the tract just in case of sinus. And we scrape whole of the granulation tissue from the sinus tract, fistula tract, and lay it open and let it heal by secondary intention. So disconnect both ends, prevent the union of the affected organ. That is very important. Suppose we have closed this, and we should place something in between the two surfaces which we have closed or repaired. So that could be your omentum. So we can place the omentum between the two, otherwise what will happen, they will, if the raw areas touch each other, and they again will unite and may again form the fistulous tract. So place the omentum. Most fistulas close spontaneously. In case of high output fistula, where the discharge of the content is more than 200 ml per day, so there is loss of fluid, there is loss of electrolytes as well as proteins. So we have to replace the proteins, electrolytes and the fluid till the fistula closes spontaneously. We have to ensure that there is no distal obstruction. So we have to give the nutrition through intravenous route if it is possible. If it is possible, we have to give the nutrition through alimentary canal, through intestine. Suppose there is a fistula in the duodenal area or in the stomach. So we can simply do jejunostomy, feeding jejunostomy. That is, feeding tube is distal to the site of the fistula. We can feed the patient. You can see adequate drainage distally, output measurement and replacement of the lost fluid and the nutrients. So similarly, in this case of your high output fistula, we have to keep the patient nil orally, nasogastric aspiration, bowel evacuation, intravenous fluid, elemental diet is far safer and more easily absorbed, along with least complications associated with the intravenous feeding. So feeding jejunostomy we can do below the fistulous tract. If the fistula by this treatment is not closed between 7 to 10 days, or maybe we can wait few more days. If it is still discharging high amount and of the content or the fluid, and that fluid is not decreasing, we have to do surgical repair of the fistula. So all these fistula tracts, they heal spontaneously provided we have removed the tract, we have laid open the tract and scraped whole of the granulation tissue. We have controlled the sepsis, we have controlled the systemic diseases. So all those factors which lead on to non-healing or delayed healing of the wound also play a role in the non-healing and delayed healing of the sinus and fistula. Thank you very much.